here we go. So this is a tale of a terrible night I had in the resuscitation room recently. I had only one patient, and it was this patient, but I was with him for 12 hours straight. And we had no phone connections this very terrible night. So you can imagine I could contact no one. So it was pretty much on my own. And it had been quite a calm night until one of my co-residents that was actually in the regular medical area told me, I have a patient that you need to see right now. And you will understand why when I tell you the physical exam. But let's start with the history. So this was a 25-year-old man, and his chief complaint was 1 week of epigastric pain. And I'll jump right into the HPI. So he had started this epigastric pain around a week ago that gradually worsened in intensity until it was a 10 out of 10. The pain was constant and radiated to the back, and there was no change with eating or with bowel movements. He also endorsed constipation, nausea, and vomiting. He denied melena, hemochromatosis, abdominal distension, pruritus, skin changes, dark urine, or other complaints. So it was pretty much this very intense epigastric pain that had been bothering him for a while until it was so unbearable that he came to our emergency department and was actually initially seen by general surgery and later internal medicine by my co-resident who brought him to my attention. Yeah, I'll pause here.
Well, I'm not sure if it was intentional or not, Katerina, but I think some of us may have heard you say this patient was a 25-year-old man, which made my heart sink. Okay, good. I'm glad he remains a 25-year-old man. That gets at how powerful and how important the clinical trajectory is. And here the clinical trajectory is very, very informative, but we'll reflect on that later. I think let's clarify what we know for a fact, that this person has had debilitating and progressive epigastric pain to begin with. And I'll study that along with its radiation to the back and pass the mic to Prof. Rez for any other comments he has, and all the other data that we're getting on the board right now. I find epigastric pain to be very complicated and tricky because the epigastrum provides poor localization to the origin of the discomfort or the pain. It could be as far away as an acute myocardial infarction in the right coronary artery, a pulmonary disease process, a mediastinal disease process, a disease process that toggles between the mediastinum and the abdomen in the form of distal esophageal or proximal stomach disease, extends into the stomach, the gallbladder, the spleen, the pancreas, and the vasculature. That's many things to keep track of. So when you're trying to get to the bottom of epigastric pain, all you need to know is you have to entertain anything within a 5-mile radius of the epigastrium. That's just the reality of it. So you have to study accompanying features to make progress. And those accompanying features are what happens when the patient exerts him or herself. Is this epigastric pain on exertion, or is it epigastric pain with other forms of stress? And the other forms of stress may be eating. As a stress test for the digestive organs. Here, the accompanying clue is radiation to the back. That helps. So what are diseases that involve the epigastrium that prominently radiate to the back? Prominent radiation to the back implies that this epigastric disease process extends into the retroperitoneum, which implicates the retroperitoneal organs that either live purely in the retroperitoneum or transiently pass through the retroperitoneum. And while the DDX of that is broad, it focuses the spotlight on vascular disease processes, as the aorta is a primary retroperitoneal organ that perforates through its vessels into the peritoneum, one, and then to a subset of GI disorders that course through the retroperitoneum, primarily the pancreas, but also the duodenum and the ascending and descending colons. So for me, the immediate question is this a vascular disease process or duodenal, pancreatic, or colonic process. None of these hypotheses matter because no matter what you tell me about this patient, I already know that he needs an EKG, a chest X-ray, and a CT. So those are all things that the severity of his pain mandates. And so these are purely speculative, designed to make sure that you analyze those subsequent data that are necessary in this case in the appropriate context. All right, Prof. Rez, back to you for any comments on the negatives or the other data and any reflections you want to add.
I have nothing to add. Anne-Marie, did I hit it? That's my Batman voice.
That was pretty good, I must say. That was. I've not been following the chat. I was like, what is wrong with him? And then, yes, great job.
Okay, let's keep going. So his past medical history was relevant for paroxysmal supraventricular tachycardia, and he'd been seeing a cardiologist in our institution because of this. And he'd also had COVID 3 times, in January of 2021, in November of 2021, and around 2.5 weeks before presentation. But he'd been vaccinated in August 2021 with just 1 dose. His meds were only bisoprolol, 2.5 milligrams a day for his supraventricular tachycardia. His social history, this is a Brazilian student that had been living in Portugal for 3 years with his family. Lived in an urban area with normal habitability conditions. He was an occasional cannabis user, but he didn't smoke cigarettes or use alcohol. And he was allergic to seafood and chocolate. And so now I will reveal why my co-resident was so desperate for me to see him. On his physical exam, his temperature was 38.4. His BP was 60/40. His heart rate was 80. His respiratory rate was 30. And he was sitting at 98% with a non-rebreather mask at 15 liters. And this was what he needed to set appropriately. He looked very uncomfortable, pale and diaphoretic. He was quite somnolent, but rose to verbal stimulation, and he was oriented ×3, and no focal signs were present at the exam. And his abdomen was non-distended, but tender to palpation of the right upper quadrant and epigastric region with guarding. And his extremities were cold and poorly perfused. And at his pulmonary auscultation, he had reduced breath sounds in both bases, and the rest of the exam was normal. And because my co-resident saw this and he had no idea how long the patient had been like this, and he was 25, he was like, you need to see him ASAP. And he was located to the resuscitation room where I was for evaluation. Yeah.
Oh my gosh. Katerina, I am anxious and nervous for this patient. I'll tackle the background and vitals, but I would love for Robbie to layer on with the rest of the physical exam. And with regard to the background, just very briefly, this paroxysmal SVT represents a narrow complex tachycardia. And most often it's either AVNRT or AVRT. And quite frequently, with 96% cure rate, these arrhythmias can be ablated. So if you're in an practicing environment where there's an electrophysiologist and you have someone come in with a narrow complex regular tachycardia with a short RP interval or even a long RP interval, there's a very high likelihood that you can cure that patient. In such a young patient, it would be unlikely that they have underlying structural heart disease, though you can't necessarily exclude that possibility. With regard to the COVID background, we just have to think in someone who gets COVID, what are they at risk of, down the road? One of the possibilities is clot. So someone who has COVID is hypercoagulable, they can have a thrombus, and you can easily imagine the same way you have cerebral venous sinus thrombosis, you could have, for example, a portal vein thrombosis in the context of COVID. The metoprolol is crucial here, folks, because you have to take the metoprolol into context when you're analyzing the vital signs. And right here, almost the epigastric pain takes a back seat to the severe hypotension this patient has. The reason that such a young patient with a likely normal conduction system is not having a much more robust response, because remember, blood pressure is cardiac output times SVR. The way the body responds to hypotension is to increase that heart rate, increase that contractility and stroke volume, and increase the systemic vascular resistance. So you might say, why is it only 80? Well, it's because this patient's on metoprolol. So I would be cautioned before saying this is a pulse temperature dissociation. It's most likely metoprolol. So now you have hypotension, severe hypotension. You have this tachypnea, but the tachypnea is probably going to represent metabolic acidosis and the patient trying to compensate for the metabolic disturbance from the hypotension and the lactic acid acidosis that has developed subsequent to that. So with severe hypotension, you just anchor yourself in distributive shock, hypovolemic shock, obstructive shock, cardiogenic shock. There's only like really a few things you can do on exam to make any more progress. One is touch the patient to see if they're warm or if they have a fever. That fever automatically puts you in distributive shock, but it doesn't exclude the other possibilities of shock or hypotension in a patient. The other thing you can do is use the stroke volume, which is systolic blood pressure minus the diastolic blood pressure, but be cautious with that, because when you're this low, there's really not much you're going to be able to gain from that. So you can't look at this and say, oh, it's low, so it's either hypovolemic or cardiogenic. That would be a mistake. So I think right now, with just the vitals in the background, severe hypotension, that fever prompts distributive shock, but it does not rule out hypovolemic shock, for example. And the tachypnea is most likely a respiratory compensation due to the metabolic acidosis from the lactic acidosis due to hyperperfusion and inadequate oxygen delivery for aerobic cellular metabolism. With that being said, I'd love to hear Robbie's thoughts on this. And Robbie's an ED provider, so this is his bread and butter. So would love to hear how he reacts and how he layers in the abdominal exam.
Yeah, thank you, Professor. I think that the analysis, how far you can take the background and vitals is incredible. And I think that when you layer on the powerful signature of this disease on the surface of this patient's body, you know that you need to take a look. So the truth is, if you're approaching this exercise authentically, you're like, what do I need to do to stabilize the patient? Central access, along with the infusion of antibiotics and pressors. And what do I need to do to get to the bottom of this? Is CT, chest, abdomen, pelvis. I think the odds of the CT not revealing, the odds of the imaging chest X-ray, pan CT essentially, the odds of that not revealing a powerful, significant clue are very, very low. And the reason for that is that once the pathology has risen to the surface to this degree, it's hard to imagine that it's still hiding when you take a deeper look in. And so the question is, how can you be armed with being better prepared to act beforehand? And I think that's probably already happened. I think Katarina's colleagues has involved your general surgery colleagues to see if this patient has a perforation. I think that the only things that would give me pause and be guarded for is to make sure that you are ready and able to identify the source of the problem and be wary of distractors. So distractors might be formulated in this way. The patient has cardiogenic shock because of Takotsubo's cardiomyopathy as a result of devastation in the belly. And so you might focus too much on the cardiovascular collapse when that is in fact a reaction to something else. You might focus too much on the marked hypoxemia diagnostically, only to realize that that's ARDS from severe pancreatitis. So the key elements of this case are to continue to systematically analyze all the data and be ready to be fooled in some ways by disease processes simply being consequences of the root cause. So you have to be very careful and not come to definitive conclusions, because critically ill patients can hide the true origins of their critical illness by decompensating in so many other ways, distracting the clinician from the root of the problem. So my entire focus now in the ER would be, I'm going to support the patient through the disastrous consequences of this problem, but at the same time be wary not to be misled and think the consequences are the core issue. And so I think at antibiotics, fluids, pressors, unless there's evidence of marked hypervolemia, and imaging are key for this patient. All right, Katerina, back to you.
Okay, that was amazing as usual. So I was panicking along with the patient. There were no phones. No one was there to help me. So I was mostly worried about stabilizing him and then involving the general surgery colleagues, because they were the ones that were seeing him primarily. And he already had a bout of exams that he had already done before I saw him. So he did a liter of plasma light, and his hypotension improved to 110/60. He was a little bit more alert, and that's when he told me the history. And so I had a little bit of time to go over his labs and imaging that he had already done. So that's what I'll give to you now. So his white blood cell count was 14.8. His neutrophils were 9.7. And his lymphocytes were 3.3. His hemoglobin was 14.4. Platelets 403. Glucose 86. Lipase was normal. His creatinine was 1.4 and BUN was 15. His total bilirubin was 1.2, direct 0.26. His AST was 732 and ALT was 991, with a normal alk phos at 104 and a mildly elevated GGT at 117. His LDH was 1400, CRP was 40, sodium 136, potassium 5.3, chloride 98, and his T-troponin was 0.099, which is mildly elevated in our lab, with normal CKMB and myoglobin. Okay, I shall wait for the scribe to keep going. So, ABG, pH 7.18, PCO2 38, PO2 88 with the non-rebreather mask. And his bicarb was 14 and lactate 6.7. His drug urine test was only positive for THC. His UA was normal. And his EKG showed normal sinus rhythm with a previously known right bundle branch block with no signs of acute ischemia. And he had already done an abdominal ultrasound that showed a non-distended gallbladder with no visible gallstones and no dilation of the biliary tree, but there was diffuse and quite marked parietal thickening of the gallbladder and perivesicular fluid with no other changes. So At this point, I was very confused, so I needed to pause and think, and I will pause for us to think right now.
No, there's a tremendous amount of information here, and I think that we're sitting on edge here with Katarina's outstanding presentation. And maybe I can just interpret the lab data and then pass the imaging for Prof. Rest to add in his thoughts and the imaging and the labs. And the labs are very helpful in their pertinent negatives and pertinent positives. If you're wondering how could it be that the patient could have such profound shock with the elevated lactate and have a normal creatinine, remember that it takes time for the creatinine to recalibrate with the current circumstances, and I wouldn't be surprised if his creatinine doesn't rise. The evidence for that will be in the lactate and in the liver injury. And you essentially have defined that this patient has acute liver injury. And how you define AST and ALT elevations is really important, and let me tell you why. If somebody has acute liver injury, the problem is usually plumbing. If somebody has acute liver failure, the problem is usually hepatitis or a toxin. Let me step back and clarify that. The liver is an organ that does some critical things that also gives and receives blood and drains bile. The plumbing from here on out refers to biliary excretion and vascular input and output. No different than the kidney, which receives blood and excretes blood, renal artery, renal vein, and also dumps urine. Same model. So when there's acute liver injury, defined as injury in the elevation of the enzymes, but without INR changes or encephalopathy attributed to the liver, the probability of over 70% lies in a problem either with the biliary tree or with the vascular input or output. So this patient, because he has acute liver injury, has a 70% chance of either having a biliary acute stone disease or having ischemic hepatitis. But we also have to entertain the possibility that he has some toxin on board or a viral hepatitis. If he were to have acute liver failure, ischemic hepatitis and biliary disease very rarely progress to acute liver failure. So that's when the spotlight shines on toxins and viruses. So here, when you're already, when you're dealing with liver injury in the context of hypotension, it's hard not to prioritize ischemic hepatitis. Here's the fun caveat. Ischemic hepatitis doesn't just happen in people who have shock. 50% of people with ischemic hepatitis have a normal blood pressure. And of the people who get ischemic hepatitis who have some sort of distribution of their blood problem, 90% of them have cardiogenic shock. So if you're going to implicate ischemic hepatitis, you have to start to look very closely for evidence of right-sided filling pressure elevation. And that may be with simply saying, hey, what connects lung issues, hypoxemia, and liver issues? Usually plumbing, meaning that there's something wrong with the vessels that connect the two organs. So here, you have to send off viral serologies. You have to scrutinize toxin exposure very well, but the focus is on the plumbing because this patient doesn't have liver failure. He has liver injury. And the plumbing hypothesis is further reinforced by the possibility of ischemic hepatitis, which sheds light on an organ we haven't talked about much yet, which is the heart. Those were where the labs take me, and I'd pass the mic to Prof. Rest to incorporate anything else he saw in the labs and also add in the imaging.
I think that's absolutely brilliant, Robbie, trying to localize to a single lesion to explain the patient's presentation. And I think where we are right now is it's like inflammatory shock, meaning that you can't ignore the fever. The fever in itself is like a marker of inflammation. So that, prompts me to think about various infectious etiologies of shock. And I think you pointed out astutely, and the way you could connect it to the heart is through potentially some kind of stress-induced cardiomyopathy. But if you look at the arterial blood gas, we know we're dealing with an acidosis here. And I didn't ask Katarina if we have an anion gap, but I'm going to assume that we do have an anion gap metabolic acidosis. And you would expect the patient to compensate by breathing out PCO2. So the fact that the PCO2 is normal it's actually not normal. So there's a component of respiratory acidosis. And I think this is when you get most concerned as a provider in someone who's not compensating appropriately for their metabolic acidosis with tachypnea. So I don't know what this patient's mental status is or where it's headed. So you have to be very cautious taking care of this patient. But if you really take a step back, all of these lab abnormalities with the acidosis, with the AST, with the ALT, with the LDH elevation, all of this can be explained through poor perfusion. And so the question is, why do we have poor perfusion? When you look at that abdominal ultrasound, I think you have to be open to the possibility that this patient is just critically ill. And what you're seeing there in the gallbladder wall is just a reflection of that, as opposed to the gallbladder being the primary culprit of everything that is unfolding in this patient. So I'm very interested in what the echocardiogram shows. I'm also interested in what a CT scan of the chest, abdomen, and pelvis show. But yeah, I think it just comes down to the heart, where you can explain everything through the question is, why is there poor perfusion? And you have to layer on the fever and some kind of inflammatory component to this presentation.
Okay. So at this point, I was confused because I thought exactly the same. This patient is inflamed. There is a lot of inflammation happening here for sure, but this doesn't look only like distributive shock. There is something else going on here. And I finally got hold of our colleagues from general surgery, and they too were, completely confused about this case. And they were like, well, let's see what's happening and let's order a CT scan. So that's what we did. And I accompanied the patient to the CT scan. And when we were waiting for the room to be ready for him, he suddenly turned to me and he said, "You need to help me right now because I think I'm going to die." And I was like, forget the CT scan. We're going back to the resuscitation room, and his BP plunged, his saturation plunged, and his mental status plunged. So we intubated him emergently and started him on pressors. And after induction with, propofol, fentanyl, and rocuronium, he entered complete heart block. I looked into the monitor and I only saw P waves. So I gave him some atropine and he recuperated to junctional rhythm. And he was in profound shock. And I thought, this heart is incredibly sick. So a little bit later, he was back in sinus rhythm and his BP went up, but even though he had very high doses of norepinephrine, his systolic pressure was always very low, like 85/60. And this reinforced my concern that his heart was sick. But the problem was getting the cardiologist to the reanimation room because there were no phones. So the ICU senior had to go to the cardiologist's room and knock on her door for her to come. So you can imagine how chaotic this was. The patient was sick and so was I from dealing with this. So she came and she performed an echo on him that showed moderate functional mitral valve regurgitation. His RVSP was 24 plus CVP. Mild dilation of the right ventricle with abnormal movement of the interventricular septum, and very, very decreased biventricular function. So I was right. And this heart was incredibly sick. And after we stabilized him and he was on norepinephrine and dobutamine, we took him to the CT scan. And it reinforced the gallbladder thickening that was happening, showed small volume ascites and a large bilateral pleural effusion with no other new findings. So I will pause here.
Wow, that truly a striking moment, Katerina, for a patient to say that to you. It's chilling, to say the least. Wow, and all this is happening in real time. I can't imagine like what was going through your head, but it seems like you've done a terrific job caring for this patient. I'll share some comments here, and then would love for Robbie to add his interpretation of this aliquot of information. I think you really summarize it, Katerina, that we're dealing with a sick heart. And I think what's so important in clinical reasoning and in medicine is not to fixate on one possible abnormality, meaning that patients might have multiple etiologies to explain their presentation. If we take the background of this patient, this paroxysmal SVT, that's not uncommon. Like that happens and we see it, it's not a setup for this manifestation of the patient. If it was just an isolated, a supraventricular tachycardia like an AVNRT, again, common, very treatable, rarely would explain such a presentation. Doing the echo, so when you're looking at the heart, you just have to break it down into the myocardium, the endocardium, the pericardium, and the rhythm. And here we have two issues going on. One is the rhythm, and the other is the myocardium, because this patient has a low ejection fraction, in addition to experiencing complete heart block. So now the crux of the case becomes, is there any way we can link these two together? And I think where we start with is the complete heart block. Why is this patient, a 25-year-old, experiencing complete heart block? And we're assuming at this point, like metope, of course, is not in the system. Metope is off. And he should be just really going to at a heart rate of 180 with this degree of blood pressure. So to completely have a complete heart block. So then the question becomes, why do people develop, complete heart block? And I like to remember this through a simple mnemonic. I call it the Lido mnemonic, like lidocaine. And I actually use the same mnemonic for wide complex tachyarrhythmias. I don't think it's a lights issue at all. I don't think it's like magnesium or potassium. The I stands for ischemia. It would be very unlikely for such a young person to have the typical causes of coronary ischemia. Though you can't completely exclude that. You can imagine if you have ischemia to the AV node, you can have complete heart block. You can think of infiltrative processes from sarcoidosis to giant cell myocarditis. You can think about infections here in the United States. We see this with Lyme disease and a few other tick-borne infections. The D stands for drug. So if the patient was on any kind of toxin or medication that could potentially stop the heart, that could lead to complete heart block. I'll leave it there to give the mic to Robbie to comment on either the complete heart block, the low EF, or how he's synthesizing this entire case together.
Y'all give him a round of applause. Wasn't that an epic mnemonic to explain so much of what's going on? Oh, I absolutely love it. I saw a couple of people in the chat outlining how complicated this case is. So maybe I'll take a diagnostic pause to clarify why all of us are talking about the heart. So what we knew about this person is that he came in with epigastric pain. And epigastric pain, remember, anything within 5 miles of the epigastrum is fair. So we didn't really know what was going on then. We got a piece of history that his heart has problems, and Reza just taught us that actually that's a distractor. And most people who have paroxysmal SVT, it's a benign thing and they don't have any consequences related to it. Of course, that comes into scrutiny now, but still the base rate of disease is that it's actually true and unrelated, and many young people have it. And then on exam, we learned that the patient is in shock and that he is cold, which made us worry about the heart, especially when the lungs are involved with the hypoxemia. And then the case, I think, was nearly sealed shut that there's something wrong with the heart when you see evidence of ischemic hepatitis in a case of shock. ischemic hepatitis is a marker of cardiovascular causes of shock. It really is fairly specific to it. And then that was supported by the notion of the gallbladder findings, the gallbladder being edematous, which is also a finding of cardiovascular disease that Reza discussed on the RLR case, and then reinforced by the echo. And so the question is it all about the heart? And I think the answer is yes, because everything else lumps into that except the inflammation. And so we might be dealing with a fever being a distractor. And Reza and I will tell you that our dear friend Mohit Harsh came and presented a case of a STEMI that featured a low-grade fever. So low-grade fever is important to explain only if there's more and more data to corroborate it. So I'm both analyzing that this is a one-time fever and this is a patient with bland old cardiac disease, or this actually fever is diagnostic of inflammatory heart disease. And I only have done that because I made the mistake in that RLR case to assume that the fever had to be explained, and it turned out it didn't. It was a one-time thing. And I think Reza was just emphasizing that this isn't just heart failure. This is heart failure with propensity for conduction system disease. That's a clue to filter all the causes of heart failure, filter them through what are diseases that have a propensity for conduction system disease. And I completely agree with everything he's mentioned. I also had time to look back and revisit his social history and saw that he's from Brazil and wondered, could this be related to Chagas? That would be unusual to just be completely fine and then develop cardiogenic shock from Chagas cardiomyopathy. So that hypothesis is much less likely, unless we don't know that he actually was restricting his activity and had developed cardiomyopathy from Chagas before. People who get a fulminant myocarditis from Chagas do it at the initial infection or in folks who have reactivation disease, usually from immunosuppression. So Chagas is a consideration every time you see that there's exposure plus heart, but made less likely. He also has had COVID. Could he have COVID-related myocarditis? And ironically enough, today's UCSF morning report that I joined was COVID-related myocarditis. So it may be that life is fantastically comical. I will also say that this patient has another kind of very interesting heart failure, and it is hyperacute heart failure. Most people with heart failure don't progress into cardiogenic shock 2 weeks after developing heart failure. So for me, hyperacute heart failure focuses the spotlight on valvular disease, which the patient doesn't seem to have. He has secondary valvular disease, pericardial disease, which the patient doesn't seem to have based on his echo, or myocardial disease. And there are 2 threes that I always keep track of. The first 3s that cause hyperacute heart failure are ischemia, either through conduction system disease or through massive myocardial infarction. So ischemia is a big consideration here, and the EKG will be crucial. Myocarditis, COVID-related myocarditis, eosinophilic myocarditis, and giant cell myocarditis, and then peripartum cardiomyopathy. Peripartum cardiomyopathy can take an uncomplicated pregnancy and land the patient in the ICU on the order of weeks. That's the first set of 3s: ischemia, myocarditis, and peripartum cardiomyopathy. Here are the other 3s. Thiamine deficiency, no real signal for it here. Thyrotoxicosis, no real signal for it here, except the fever maybe. And then finally, Takatsubos. And again, here's where my angst lies. My angst lies as the general internist in making sure that I don't put all my money on the cardiologist to solve this case, and making sure that this case is not us being distracted by this person having devastation in their CT that we haven't gotten yet, and all this cardiac disease be a reaction. Remember, warning, warning, warning. Don't get focused on things too much. The heart could be devastated by something else in the belly. So that's what I'm going to lose sleep over now. So what does this patient have? This patient has either ischemia, myocarditis, peripartum cardiomyopathy is not at play here, or he has one of the 3 T's: thiamine, Takatsubos, or thyroid. The thing that will cause me to lose sleep, because my job is to make sure that I, as the general internist, don't lose sight of the fact that there's something else going on in the belly. He has epigastric pain and his belly hurt a lot. Is the disease a devastating abdominal syndrome? And is the heart Takatsubos? That's my most concerning thing. But we'll see where Katerina takes us.
Okay, so yeah, that was what I was racking my brains over. Was the chicken and the egg? What came first? And even though he was on high doses of norepi and dobutamine, his hypotension wasn't improving very much, and his lactate continued rising up to like 10 or something. So we decided to call the ECMO team from our neighboring hospital, because we don't have ECMO in our hospital, and they were as scared as we were, and they came running. So we transferred him to the ICU, and he was cannulated there. And while he was being cannulated, I was thinking, like, what the hell is happening? I have no idea. I have never seen anything like this. Yeah, he has cardiogenic shock, and everything else could be explained by the ischemia, including the gallbladder. But his belly was hurting a week before. No one is in cardiogenic shock for a week. So that gallbladder, something else is going on there. So I'd already done antibiotics and everything, but our general surgery colleagues were very much convinced that this didn't look like a primary gallbladder issue, that this was something else. So I was thinking, what joins, cardiovascular collapse with inflammation in the biliary tree in this patient? And I will give you one last clue before I tell you the final diagnosis. And that it was that the next day, his LDH was 12,000 and his ferritin was 10,000. Yeah, and I will pause here before revealing the final diagnosis.
Thank you, Katerina. I think it's so intriguing. And I think all you're really illustrating is how thoughtful you are about tracking every piece of data here. And it's amazing that the biggest disconnect in your mind is the length of the abdominal pain with the length of the cardiovascular collapse. And it just goes to show how important it is to always track the time course. If you don't track the time course, you lose a lot of very precious information. And I think that initially you noticed that I actually didn't mention the LDH. I didn't mention the LDH because I think that it is actually a very powerful feature of ischemic hepatitis. Most people with ischemic hepatitis have an LDH through the roof. If, however, you start to see a disconnect between what is happening with the AST, ALT, and you start to see the LDH go the other way, you have to revisit that hypothesis and remind yourself that that LDH can come from other sources. The muscle you've disproved with a normal CK. Hemolysis you've disproved to a large degree with a normal hemoglobin. The lungs can produce a little bit of LDH, but not to this degree. So can the kidneys, but not to this degree. So if the LDH starts to skyrocket and go really, really high, you have to worry that there's actually a cell that's not supposed to be there, and that this might be a malignant disease process. And that's where I'll leave that. I know Prof. Rez actually taught me a lot about the diagnostic utility of super high ferritin. So I'll pass the mic to him to divide these two data points, and then maybe we can reflect together on what we think is going on.
Yes. First of all, Katerina, you have everyone on the edge of their seat, because this is a bonkers case. Wow. Yeah, Robbie, I'm right there with you. I think that, okay, so another mistake would be to see a high ferritin and say this can be either HLH, hemochromatosis, as the primary etiologies, because there's a really good study, and I hope someone can include it in the chat function, where it dispels the myth that super high ferritin levels are just linked to a handful of diagnoses. What super high ferritin levels mean really is that the patient is inflamed, right? The patient is inflamed. And I see Ravi pointed out another third common cause that people think of, adult onset Still's disease. So with this high LDH, I'm right there with Robbie. Like, there isn't much going for hemolysis. And I just think that you're having turnover of tissues, and I'm not getting a flavor of a metastatic malignancy. It's just not there for me. So what do I do now, Robbie? I think I just sort of step back and say, like, the ferritin is very high. You have to run through the common causes, but know that anything can cause a very high ferritin. And of those common causes, like, nothing matches up with the dot onset Still's disease. HLH, usually these patients present with bicytopenias, splenomegaly, and are significantly inflamed. And there's some overlap between HLH and the multi-inflammatory syndrome that you see after COVID in adults. I'm not getting that flavor from this clinical presentation. So then we're down with the other H, which a lot of people said, could this be hemochromatosis? And I'll ask you, honestly, I don't think of hemochromatosis presenting so abruptly. I think of that of a disease in someone who has a borderline high ferritin, high percent SAT, may have some diabetes, may have some cardiomyopathy. To present so robustly, that would be new for me, and I would have to update my illness script. So where I am, Robbie, is like, I'm not sure, what the final DX is here. And I think that I'm going to be interested in seeing what Katerina reveals. But before she does that, let me pass the mic back to you, my friend.
I completely agree with you. I have nothing to add to what you layered on, and I'm using Katerina's setup to prompt my mind to be like, well, what connections can I practice making between gallbladder disease and heart failure? And I think that the simple connections are that you have a necrotic gallbladder that causes cardiogenic shock, and that would be usually in patients with diabetes or older adults who get just gangrenous cholecystitis. So that's one connection. Another much less common connection is something that I've only seen in case reports where you have gallbladder disease and you actually embolize bile. It's a very interesting condition. So bile acid embolism is something to entertain here, but only if you really believe the gallbladder is at play. And then finally, you have to revisit this patient's epidemiology and say, we always think that hepatobiliary diseases are stones, but remember, parasites are an important consideration. So could this patient have parasitic occlusion and actually having eosinophilic myocarditis from migratory parasites? So all those are fancy smancy connections that actually probably wouldn't be thinking about in real life. In real life, I would use the ferritin to worry most about multi-system inflammation from COVID. Again, biased by this morning's UCSF report that I told you about. So if we're listening to 2 back-to-back cases of COVID, I would be humbled. And yeah, I don't get the flavor of malignancy here primarily because of the acuity, but then I'm pressing the brakes on that because there are some malignancies that can just have an explosive onset in patients. And so could this patient have that? Possible. At the end of the day, whatever this is, this will give you the opportunity to strengthen your connections between the disease processes and respect Dr. Katerina Costa's incredible diagnostic might.
And Robbie,
Yeah.
if we step back, like at the end, it just seems like there's a cytokine storm, whether you call this MIS, whether you call this macrophage activating syndrome, whether you call this HLH, whether you call this, adult onset Still's disease with panserositis, it just is telling you that this patient is really inflamed. And I think if you don't find an infectious etiology, the question becomes, does this patient need immunosuppressants? Does this patient need an interleukin, antagonist like anakinra?
Beautiful. What does he need, Dr. Costa? What does he need?
He needed this discussion at the time because I was, stumped, and I was discussing this with one of my close friends, who is an attending in my service, and he was like, I feel like I've heard this somewhere. And I was like, yeah, that gallbladder, gallbladder is speaking to me. And I think I read about this in the New England Journal of Medicine. So I went back to the articles I'd been reading like the week before, and I found the answer. And this pretty much checks all the boxes for one diagnosis. So the fever, the severe cardiac illness with the heart block and the reduced ejection fraction, the encephalopathy, the abdominal pain and the vomiting, and the high ferritin and the high CRP check all the boxes for multi-system inflammatory syndrome in adults. So this was the final diagnosis, MESA. And he was, started on systemic corticotherapy and IV immunoglobulin, and he was off ECMO in 48 hours, and his ejection fraction returned to normal. And after a week, he was totally fine and he was discharged home. So yeah, it was very dramatic, but had a very happy ending. And he's doing just fine. Like nothing happened except for the trauma of thinking he was about to die, which he was about to die.
I don't even, well, I think it's just absolutely humbling, the spectrum of disease we're seeing with COVID. I'm mesmerized by the quality of your presentation and how you just kind of slipped it in there that he had COVID so that we wouldn't dominate the story and relate it to COVID. I'm also just humbled by the crazy fortunes of life. I was literally reading for 30 minutes about my essay before this gathering because UCSF's morning report, which actually was facilitated by Jack Penner, one of our very own CP Solvers team members, of a case of severe myocarditis from COVID, and learned a lot from that report. And to have it come up 30 minutes later just makes you wonder if life is really as random as I'm told it is. But yeah, I have so many reflections to share with you. The most of it is just how much of a privilege it is to learn and reflect on cases that you present, Katarina. It's always humbling, and always humbling to share the spotlight with Prof. Rez, who I'll pass the mic to for his reflections.
Thank you so much, Katarina. I really appreciated this case because I don't work in the ICU anymore, so I don't see patients as sick as this. And it's great to have another rep in it. And I think that you still had to go through that entire exercise. Like, it would be a mistake that you see COVID in the background and you say this is Miss A until proven otherwise. It's just a diagnostic possibility. You still have to go through the exercise that you went through, that Robbie and I went through today, to arrive at this diagnosis. But by the final aliquot, you see severe inflammation that's unexplained. And at that aliquot, I think that's when prioritizing that diagnosis makes sense. But I just want to emphasize that just because someone has COVID in the background, they present with fever and hypotension, it shouldn't reflexively make you say this is multi-inflammatory syndrome in adults. You should pause, go through your DDX, but as long as you have this in the background, you know when you can deploy it to arrive at a timely DX. So thank you so much for presenting that. I know we're running short on time, so let me pass the mic to our dear friend Sammy from Austria.
Wow, what an amazing
Who
case.
seems to have written a book there in the teaching points.
Yeah, we'll just go over some quick teaching points. Thank you so much, Katarina, for the case. You know, it was amazing when the teaching points take up half of the space of the whiteboard. So thank you so much, and awesome discussion by RLR and also by the chat. I learned so much. So approaching epigastric pain, Robbie taught us that it's poorly localizable. It can be from acute RCA occlusion up to lesions of the pancreas, liver, spleen, but also the stomach, basically every organ that is 5 meters near the epigastrum. We can think about stress tests. Exercise would point us more to a cardiovascular problem, for example, coronary heart disease, and eating, epigastric pain with eating more to a luminal, biliary, pancreatic, or vessel disease, for example, intestinal mesenteric ischemia. When the pain radiates to the back, we can think about organs in the peritoneum, for example, the aorta, pancreas, duodenum, ascending and descending colon. Complications of COVID, we touched a few. Hypercoagulability is the most notorious one, but also myopericarditis, COVID mediated, but also as a complication of the systemic inflammation, ARDS, and MIS in children and MIS in adults, as we just learned from this case. When we think about shock, we can think about distributive, obstructive, cardiogenic, and hypovolemic shock. You should always look at the JVP, at the skin. Is it dry, wet, warm, or cold? What is the stroke volume? What's the mentation of the patient? What is the volume status and urine output? I just recently learned the bus mnemonic from Pulm Peeps is also pulmonology podcast, and he uses brain, urine, and skin as a mnemonic. Whenever one of these is dysfunctional, you should always jump on the bus for sepsis and evaluate in this direction. When patients are in shock and on a beta blocker, they can be chronotropic. There can be chronotropic incompetence, and lactate may be falsely low because beta blockers inhibit glycolysis, and so we also have less substrate for lactate synthesis. When you see a normal creatinine in the setting of shock, you shouldn't disregard it, and it will most likely rise in the next hours. The most common cause of ischemic acute liver injury is right heart disease, so you should always think about it. Of all the causes of right heart disease, most notoriously left heart disease. Then we also talked about the difference in acute liver injury and acute liver failure. Acute liver injury, only AST and ALT elevation, mostly caused by a plumbing issue, for example, with the bile excretion, vascular input or output. And acute liver failure is associated additionally with an elevated INR and hepatic encephalopathy, and the most common culprits are hepatitis or toxin. Whenever we see gallbladder inflammation in a septic patient and we don't see gallstones, we should always think about acalculous cholecystitis in the setting of systemic disease and look for more clues, and maybe don't focus too much on the gallbladder. Yes. When we have systemic inflammation with signs of shock and progression of cardiac conduction abnormalities, we should always think about cardiac inflammation. And as Reza taught us, we have the endocard, the myocard, and pericard, and all of these layers can be inflamed and dysfunctional. Then we also learned the Lidom mnemonic for progressive heart block. Should think about light, electrolytes, magnesium, potassium, phosphate, ischemia, or infiltrative disease. The most hyperacute one is giant cell myocarditis, but also sarcoid, amyloidosis, Lyme, Chagas, also drugs, and hypoxia. Whenever we approach hyperacute heart failure, we should think about ischemia, myocarditis, peripartial cardiomyopathy, wet beriberi, thyrotoxicosis, and Takotsubo cardiomyopathy. And another pearl that I just wanted to share and recently learned is whenever we have the excessive ferritin, HLH isn't the most common cause, and mostly it's systemic inflammation and cytokine release. So we should always think about other causes first, but other causes also include adult onset Still's disease, multi-inflammatory syndrome, and hemochromatosis. And CXCL9, which is a new marker, can be helpful because you can differentiate from primary versus secondary HLH versus other causes of systemic cytokine release. So thank you all so much. I really enjoyed this hour with all of you and hope you all have a nice day.
Round of applause for Sammy, who not only taught what we taught, but added to it and made it sound better. Sammy, really incredible job teaching. Thank you for that. Thank you, Katerina. RR, hope you all have a lovely weekend. Thank you for joining. Take care.